Good afternoon, everybody. My name is Anja Frey, and I'm very happy to co-chair this webinar together with Gerrit Hussers, our COPD cohort leader. I am a senior researcher from the University of Zurich, and I'm responsible for the Swiss COPD cohort of the clinical validation study. We researchers from the COPD group are actually a group of friends who have been working together for many years. And most of us have already been involved in another EU project, Proactive. We are now very looking forward to contributing together to the exciting Mobilise-D project. Just for your information, as Mara already told you, we will discuss questions at the end of all presentations. But if you have very specific questions during specific talks, please just write them into the chat. I will now hand over to Gerrit Hussers, our Mobilise-D cohort leader, who starts with a general introduction to this webinar. Thank you.
And thanks very much, Anja, for the kind introduction. Indeed, it's a pleasure to co-host this webinar on mobility in chronic obstructive pulmonary disease, where we can, for the first time, I would say, discuss what the COPD cohort is doing within the Mobilise-D project. I'm Gerrit Hussers. I'm from Leuven University, the Department of Rehabilitation Sciences, and really excited not only to chair this webinar, but also to work together with a group of friends. I think we can call ourselves friends now after all those years in Proactive and later in Mobilise-D. Let's hope I can move to the next slide. Yeah. So the Mobilise-D cohort, very briefly, is a very large cohort which spans different chronic diseases. Today we will be discussing the COPD cohort, but there's also Parkinson, multiple sclerosis, hip fracture included, all of which are looking into how we can make our patients more mobile or how we can use that as an outcome measure. The overall project is chaired by Lynn Rochester and Ronan Rubinov from Novartis, and the COPD cohort is a subsection of this cohort. What we will discuss is the truth and nothing but the truth, but it's our own vision. It's not necessarily the vision of the European Union or the IMI or the EFPIA members. We have to say that at the beginning of each of these meetings. So as I already said, we are really a group of friends, mid-career investigators from all across Europe. We have people in Newcastle, in London, Leuven, Groß-Hansdorf, Zurich, in Athens, and in Spain. And we are working closely together with each other on the team of COPD. And what we really want to achieve, and what I hope you will understand after this webinar, is that we're trying to move out of the lab and out of the hospital and get into assessments of patients in real life. And so in the hospital, we are used to looking at lung function and walking tests, and we take questionnaires, and we can look at blood samples or other stuff in that setting. But what we really want to know is how patients develop in their home situation, in real life, where the interventions that we do on patients really matter. And so in this webinar, we then opted to have the views of different stakeholders in this whole process. We wanted to see how clinicians look at this and what the challenges are moving from the lab to home, and what the challenges are to clinicians, to industry and regulators, to academic researchers, and to patients. And the different speakers will basically speak to these topics. Each will have their dedicated topic. And we will obviously also discuss the study protocol. And in the end, Dr. De Meijer from Leuven will discuss this. We have, I think, a great panel of not only experts, but PIs and investigators, young and somewhat older, from the industry, brought together for you. We have Henrik Watts from Germany. We have Sarah Shrew from Novartis. Enfin, we will introduce the people as we go through this webinar. And so without further ado, I'm happy to introduce the first speaker, but not before reminding you that if you have any specific questions to Dr. Henrik Watts, please put them in the chat and we can take them after his presentation. If they're more conceptual, we will take the questions rather towards the end of the presentation. But Dr. Henrik Watts is a chest physician from Groß-Hansdorf in Germany. He leads the German part of the COPD cohort. He has been involved in much physical activity work in the field of COPD, both in academic studies, but also in clinical trials with the industry. So I think he's very well placed to give us an introduction to COPD and to talk us through that. For those of you who are less familiar with what COPD, what chronic obstructive pulmonary disease is. So Henrik, over to you.
Yeah, thank you, Thierry. Warm welcome. Good afternoon. I'm speaking from Großhansdorf. For those of you who don't know where Großhansdorf is, because it's not Zurich, it's not Leuven, it's not London and Barcelona. It is a small village close to Hamburg in the north of Germany. And what I would like to do now is to make a few words on COPD in general, to make you a bit more familiar with this respiratory disease, and then get to the important consequences of COPD, which is reduced mobility or physical inactivity, and make a few words on the clinical relevance of this important consequence of the disease. So COPD is clearly a lung disease. It is defined as a lung disease, but on the seeing the patients below the definition, you already see the important consequences, which is breathlessness and physical inactivity, muscle weakness, muscle dysfunction, cachexia on the left-hand side in this patient. And this is all due to COPD. And what I will now do is use a few of the key attributes, characteristics mentioned in the definition to get you familiar with COPD. Though there are two fundamental pathological processes occurring in the COPD lung. One is the airway component, airway disease, which is a predominant small airway component, small airway disease. And the other one is the destruction of the alveolar compartment, which is called emphysema. So the loss of the alveolar surface, which is needed for gas exchange. But airway disease, the obstructive component, constrictive in the upper picture to see, and the inflammatory component with the obliteration of the small airways due to mucus, and the loss of elastic recoil due to emphysema, because it is not only a destruction of the alveoli, it is also a reduction of elastic fibers and a loss of alveolar attachments close to the small airways. This results in the situation that the patients can't empty their lungs during expiration, which is causing the most troublesome and key symptom of COPD patients, which is dyspnea, and which we can assess and measure and quantify using spirometry, assessing the airflow limitation during expiration and the subsequent lung hyperinflation, air trapping, which are all related to dyspnea. The inflammatory component, the inflammation is with the symptoms cough and chronic sputum production in our patients. Though with this first slide, I would like to introduce you to the clinical problems we have and how we assess them in our patients. So the definition also says that COPD is common. In fact, it is highly prevalent, but we don't have exact numbers how prevalent it is. It might be still significantly underestimated. The global prevalence estimated to be close to 12%, because in many countries patients don't have access to spirometry, and in other countries where spirometry theoretically would be available in primary care, it is still significantly underused. So this is only the first estimate that we have from a few epidemiological studies that have been conducted in very few countries so far. So COPD is not asthma. COPD is the disease of the elderly. And it needs to have, in most patients, a significant exposure to the noxious gases and particles, which is in most cases still smoking, but there are also many other causes, biomass, fuel exposure, air pollutants, and also genetics and early life origins, a lot of or infections early in life, which can at the end in the elderly population result in the clinical disease that we call COPD. And for those of you who are interested to read more about this, there's a recent Lancet Commission paper going into details of COPD, and Thierry Trosters is one of the key authors of this publication. So for you, for those of you who are interested to learn more, then could be done with a few slides. You are referred to this paper. So it is, COPD in general is still in most countries a male predominant disease, which is also related to the smoking habits in the past. So COPD is not only common, but it is also a very deadly disease. Some say it's the third leading cause of death. Others say it's the fourth or the fifth leading cause of death. In this projection from the World Health Organization, it is the fourth leading cause of death. I still think it is completely underestimated because many of our patients die from cardiovascular disease, from pneumonia, and also from lung cancer. And in this situation, COPD does not count or is under-recognized in these clinical situations, though the truth might be even more sad in terms of the listing of COPD as one of the most common causes of death worldwide. So it is exacerbations, severe exacerbations, hospitalizations, which are a main driver of mortality. The acute worsening of COPD occurring with a background of infections or other inflammatory events. So it is detrimental situation for our patients having breathlessness and need additional treatment. So many patients can be handled in this situation in an outpatient setting with the prescription of systemic steroids and or antibiotics. But many patients also need hospitalization because the acute events called exacerbations are so severe that they need to have hospital care in the situation. And you see that it is the number of exacerbations which is important for the patients, because it results in the situation that a hospitalization is more likely in these patients, and the hospitalization itself are clearly related to the high mortality of our patients. So this is why exacerbations are an important outcome in our Mobilise-D cohort, and Helene de Meyer will afterwards go into details how we collect the information and why we think it needs to be clearly connected with physical activity and mobility in our patients. So the definition says it is treatable. Yes, it is. And it is most of all the non-pharmacological treatment options that we have with smoking cessations in those patients who still smoke, with vaccination, mainly pneumococcal and influenza vaccination, and rehabilitation being the cornerstone of the therapy. But rehabilitation is much more than exercise training, as illustrated in this picture. It is much more than that. It is also smoking cessation and many, many other interventions that are very, very helpful for our patients. So compared to that, our impact by the pharmacological treatments that is currently available to us is very limited, to be honest. So all what we can do is address the airway disease component with bronchodilation of the constructive remodeled small airways. We have new drugs available with 24 hours or 12-hour duration of action. So they are also combined with certain combination therapies available to us. We can address the inflammatory component by of the airways with inhaled corticosteroids in those with higher eosinophils. With PDE4 inhibitors, there are also some drugs under development addressing the inflammatory component of the small airways. There's nothing that we can do pharmacological about the emphysema in our patients in this situation in a very selected population. In the clinical situation, we think of a reduction of the lung volume. This can be either done endoscopic or by surgery, but this is a very limited option for very selected severe COPD patients. So our patients don't care about lung function, and we as clinicians also less care about lung function. I would say the patients care about breathlessness, and we know that breathlessness is a trigger for the clinical worsening of our patients called the downward spiral of the disease, with breathlessness triggering the avoidance of this situation. So the reduction of physical activity is a consequence. And from the clinical perspective, we know for many years that this results in the deconditioning and more exacerbations and worsening of our patients. So breathlessness on exhaustion and physical activity are closely related. And this could be shown in sensor-based physical activity measurements that we did a few years ago. And you can see the close relationship between the level of dyspnea and the physical activity of our patients, with a dramatic impact, especially in higher MMRC grades in terms of a complete reduction of their physical activity. And Thierry mentioned it, we are all studying physical activity for 1 or 2 decades, I would say. We started with the measurements in our patients, and this is just a few publications from our COPD group within Mobilise-D on the left upper side, showing that the deconditioning is related to physical inactivity with a dramatic loss of muscle mass and also exercise capacity, that it is related to exacerbations with data from the Barcelona colleagues, and it is clearly related to mortality. And Helene de Meyer could collect a huge sample of European subjects from all countries participating here also in Mobilise-D, showing that the impact is of particular importance in GOLD stage 3 and 4, which are the severe COPD subjects, the impact on physical inactivity on mortality. We also have some first ideas what might be a clinically relevant change. This is again data from the Leuven colleagues showing that after severe exacerbation with rehabilitation, in those patients who had an improvement of physical activity, there was a clear reduction of subsequent rehospitalizations, because we know that one hospitalization always results in a high probability that our patients will be rehospitalized due to the severity and the clinical course of the disease. And here you see that as little as 600 steps per day as a change, as an improvement, might be already meaningful, because the number of rehospitalizations could be clearly reduced. We also started to look what happens when we improve lung function, when we improve the breathlessness of our patients, and we started with to also see what happens with the physical activity of our patients. And you see that the signals are numerically in the right direction, either maintaining the physical activity on the left-hand side with mono bronchodilator therapy, or showing some improvements on the short term with dual bronchodilation. So the signals might be in the right direction, but Dimitrios will go into details because he studied it in detail, the available data in Mobilise-D. And finally, there are also other drugs under development in COPD, not only bronchodilators, and this is a study coming from the lead authors coming from the Imperial College in London, also partners here in the Mobilise-D consortium, showing that targeting muscle weakness does not only result in improvement of muscle mass and improvement of muscle strength in some patients, but we also started to measure physical activity in this clinical study, and there are also the signals, as I would call it, numerically in the right direction. This was a small cohort, small study only, but nevertheless, we started to measure physical activity because we think it is of clinical importance. Thank you for your attention.
Thank you very much, Henrik, for your really interesting presentation and your introduction into COPD. I don't see any specific question for you, but you all have the possibility to ask questions at the end of all presentations, as we discussed before. So thank you, Henrik, again. And I'm now very happy to hand over to Sarah Battery and to present shortly her. Sarah will provide an input regarding the importance of assessing real-life outcomes in COPD, which are really important in our project, the real-life outcomes. Sarah is a research physiotherapist and a PhD candidate at the Royal Brompton and Harefield NHS Foundation Trust. And she's a researcher in the Mobilise-D consortium with a group of Professor Hopkinson in London, and currently is involved in collecting data for the clinical validation study, and she also worked for the scoping review. She's also a member of the Patient and Public Involvement and Engagement Board of Mobilise-D, which is also a very important board. And she has published on patient-reported outcomes in several lung diseases, including COPD, in both quantitative and qualitative studies. So she is really an expert in the outcome field. So I'm really happy to hand over to you, Sarah.
Yeah, so as I was saying, Henrik has already really clearly shown in his presentation that COPD is a multifactorial condition, and in which an individual can suffer a number of symptoms that can affect their experience of living with COPD and how they're actually able to participate in daily life. And traditionally, the assessment of COPD and its treatments have relied quite heavily on using lung function, or FEV1, as an outcome measure. But FEV1 doesn't really fully reflect the burden of COPD on a patient's life, and it also doesn't correlate very well with symptoms. So, for example, how their subjective experience of breathlessness impacts on their daily life. But an outcome that does have stronger relationship with many of the components of COPD and of particular importance to the overall burden of the disease is physical function or mobility. And this diagram shows mobility and impairment in COPD is associated with a number of different components that are of importance to both the patient and the clinician in COPD management. And these include reduced quality of life, falls, increased hospitalizations, a loss of independence, which can in turn lead to social isolation and loneliness, and also to increase mortality, which is obviously very important. This study that was published a while ago showed the relationship between physical activity and all-cause mortality. And it did this by showing that a lower physical activity level, based on steps taken per day, was associated with a greater risk of mortality over a 4-year period. And this is shown in the survival curve, where we can see this dramatic decline in the probability of survival in those patients that are very inactive. And this is in comparison to this sort of slower, more steady decline in the sedentary group, and then very much so in comparison to the active group, where there was no deaths over the 4-year period. So as you can see, mobility as an outcome is very important as both a prognostic indicator, but also to many components in COPD, and really reflects the burden of the disease. So how do we measure physical function and mobility in COPD? And this has been done usually using either a subjective outcome, which can be either patient-reported or clinician-reported, but both do suffer from shortfalls in being able to accurately measure what we want them to. And so first of all, patient-reported outcomes are subject to recall bias. Which makes, for example, if we're asking a patient to talk about how much activity they've done over last week or last 14 days, that is quite difficult for a patient to remember and accurately describe to us. And also, it's difficult for them to quantify the duration, the intensity, and the frequency that an activity is carried out. And the measures that we use often ask about activities that many of our patients that we're using these measures with just don't participate in. So, for example, occupational activities or recreational activities that are carried out outside the home. So, yeah, many of our patients just don't partake in those activities. Finally, research has also shown that patients completing these questionnaires tend to overestimate how much physical activity they do on a daily basis. And a two-part study that was carried out by Fabio Pitta and his colleagues confirmed this. They did this by giving 13 patients with COPD an activity measure and then asking them to also record their physical activity level hourly. This was then this information was then compared, so the subjective information that the patient had recorded against the activity monitor, and the results showed that most of the patients overestimated their activity levels compared to what was recorded by the monitor. And this is shown in this figure, represented by all the dots that are below the 0 value. So as you can see, subjectively, patients can overestimate their activity, which makes them perhaps not the most reliable measures. And the other method of measurement is an objective measurement, usually in the form of performance-based exercise capacity tests. So some of the barriers with those. So first of all, these assessments can be quite time and resource intensive, and this is for both clinician and for patient. For clinicians, tests such as the 6-minute walk test do require a practice test because of what we know about the learning effect associated with these tests. And this can be quite difficult in clinical settings. And then for patients with COPD who have particularly severe symptoms or may live a distance away from the service providing an exercise capacity test, this can be quite problematic. Also, objective exercise capacity tests can be subject to clinical interpretation, which can affect their reliability. And then, perhaps most importantly, these tests do not assess patients in their usual environment, but rather in a controlled setting, with a clinical or a laboratory. The problem with this is that it only provides a snapshot of an individual's performance on that particular day, and that's not really representative of a real-world behaviour. Because in COPD, we know that symptoms can be fluctuating and patients can have good and bad days. And so they don't provide a real fair representation of an individual's ability. They also don't account for environmental factors that an individual has to encounter on a daily basis. So, for example, uneven roads, inclines, weather conditions. And for these reasons, along with a possible Hawthorne effect, where a patient does perform better during a test environment rather than what they actually do in their daily life, we do find that patients overperform compared to everyday life. So compared with real-world walking, patients do consistently walk faster and produce higher quality gait patterns during normal walking in a laboratory setting. So I just want to talk a little bit about this really important study, which was published very recently and helps us to give us a better understanding of the importance of physical functioning in COPD in terms of both physical capacity and physical activity, which are obviously related, but also very separate concepts. And this did this by categorising patients into 1 of 4 quadrants, and this was based on whether an individual can do, so what their physical capacity was. So this is based on the objective performance-based test that we talked about, and if they do, so their physical activity. So, and this is based on steps taken per day using an accelerometer. And the results of this study demonstrated, which are shown in this visual abstract, that both the male and female survival curves confirm that over 6 years, mortality risk was significantly lower in those that with a preserved physical capacity, and this was actually regardless of their physical activity level. And so this importantly shows us that both physical activity and physical capacity can help us in predicting prognosis. But as well as this, the relationship with mortality, what we also learned from this important study was that the work that was done in categorizing these patients into one of the 4 quadrants helps us to understand what that might be needed in terms of treatment interventions for an individual. So, for example, those patients that can't do but do may need pulmonary rehabilitation to improve their exercise capacity. But for those that can do but just choose not to or don't do in their home environment, a behaviour-based intervention may be more suitable. Or alternatively, a combination of these two might be necessary. And this is really important for us, the combination of these two, in making steps towards more personalised medicine in COPD management. So just to talk a little bit about the advances in objective physical activity measurement using accelerometry and being able to look at physical activity as a more real-world, real-life measure. I've shown a picture here of the Roberts Move monitor, which is the activity monitor that we are using in Mobilise. As you can see, it's very small, it's thin, it's lightweight, it's very comfortable for a patient to use for prolonged periods. So throughout the day and also while sleeping, we don't find many people say that it's too uncomfortable to wear overnight. So it's very practical. And from the table that I've included here that was taken from a physical activity white paper, you can see that we can collect a very rich amount of data and look at physical activity from many aspects. So the amount of physical activity that's being done, also the intensity, which is of great importance, and how much energy is it being expended during an activity, which visualizes this a bit more for patients, because walking sort of for 5 minutes for a young patient is very different for a more elderly patient, or for example for a patient that's obese compared to one with a normal BMI or a frail patient. So this really is also quite an important outcome. And then also the sedentary behaviour. So as well as looking at what patients do, it's very important to look at what they don't do. So as I've shown earlier in the slide about mortality, those patients that are more sedentary are more at risk of having a higher probability of so it's very important to look at physical activity and then how we can intervene and plan treatments according to this. So just to look at in a bit more depth about the benefits of using real-world outcomes and accelerometers. So they can be monitored over a prolonged period. So rather than based on one single observation in a clinic or a laboratory, we can look at this over a prolonged period and also multiple times. So rather than just, for example, once a year, we could do it 3 or 4 times a year with little effort. So really monitor patients to see if there's any decline and intervene as needed. It reflects real-world environmental conditions rather than that controlled environment. We can measure multiple parameters, so gait speed, walking bouts, step count, sleep parameters. So again, we can get some really good information about a patient's physical activity levels in their own environment. Also their behaviours. So it could be useful to understand the patient's physical activity during the course of an exacerbation or in the period following it. And again, can help us to know how to intervene at these points so that a patient doesn't have a significant deterioration in this point that's more difficult to come back on and can affect prognosis. It could enable users to engage in managing their own health a bit more and also facilitate efficient decisions about treatment. So again, this self-management, empowering patients a bit more to get involved in their treatments. And they have been found more sensitive to change, particularly lower levels of activity than clinical measures, without being subject to the interpretation of clinicians. And then finally, they are more time and cost effective and usually less burdensome for the patient. And lastly, I just very quickly want to spend a little bit of time talking about the proactive tool, which is pictured there. And I've spoken a bit about some of the drawbacks of using subjective outcomes to measure physical activity, but I do want to recognise the importance of the patient's experience in the concept of physical activity. And this was investigated in a large body of work conducted by the European Proactive Consortium, who developed the Proactive instruments. And this is a hybrid tool combining a patient-reported outcome and an activity monitor data to help to more accurately assess a patient's physical activity level and their experience of it. And so the preliminary work, which was qualitative, that was done in developing this tool, found that patients perceived two domains of physical activity. Firstly, the amount. So this was then measured using some subjective questioning and some activity monitor data. And then secondly, the difficulty. And this was made up of the symptoms during an activity and also the adaptations that needed to be made, such as pacing to an activity. And the Proactive tool assesses both of these domains. So it uses a hybrid method of the subjective questioning and also activity monitor data. And the findings from this study that developed this tool reported that using this combination of the two types of monitoring outcomes provides a better was a better measure of activity than actually using either alone. So again, really important to use a patient's real-world experience of activity as well as the accelerometer. So I've gone some way in trying to convince you why a real-world outcome is of such great importance in COPD management, in better reflecting the many dimensions of COPD, which include the behavioural, the social and the psychological aspects, and also in the different ways it can be useful to help better predict prognosis and in planning and assessing treatments, improving self-management, and also in collecting richer data in a research setting. So thank you very much.
Thanks very much, Sarah, for this very nice overview. We're moving from one Sarah to another. I don't see any specific questions in the chat or Q&A section. We're now moving across the pond to Boston in the US, where we find Sarah Shu. And this is one of the nice things about this project. You as a researcher, you're often engaged in projects with colleagues, but here in the Mobilise-D project, we're also collaborating with the pharmaceutical industry in a pre-competitive space. And so I'm really happy that Sarah could join us from Novartis. She's the medical director of respiratory diseases at the Translational Medicine Institute of Novartis, biomedical research. And on top of that, she's also a pneumologist in Boston. So we're really happy to have Sarah's view on how she looks from a pharmaceutical company perspective to these digital mobility outcomes or digital outcomes in the use for clinical trials. And Sarah, the floor is yours.
Thank you for that kind introduction and the opportunity to join this webinar. So I thought I'd just speak briefly to how the digital biomarkers and specifically digital mobility outcomes really have the potential to impact the development of therapies for COPD from an industry standpoint. Dr. Watts earlier showed us how prevalent COPD is worldwide, and depending on the source you go to, it's ranked either the third or fourth leading cause of death and associated with a lot of morbidity, loss of quality of life, loss of productivity, and a significant healthcare burden globally. But despite this, no new therapies with a novel mechanism of action have been launched in over 10 years. The most recent one was back in 2011 with roflumilast. And even then, the use of roflumilast has been significantly limited by the side effect profile. So why is this? Why is it so hard to develop successfully a drug for COPD? I think there are a lot of reasons, including the fact that COPD is a very complex disease. It has a complicated pathobiology and heterogeneous clinical manifestations. But from a practical standpoint, it's also not that easy to run clinical trials in COPD. Many of the so-called registrational clinical trials for COPD, in other words, the trials that are needed to get sufficient data to support a filing for regulatory approval, whether it's from the European Medicines Agency or in the US, the Food and Drug Administration, have endpoints that really aren't that easy to meet. So for COPD, one of the most common and widely accepted primary endpoints for phase 3 trials is acute exacerbations that Dr. Watts also alluded to. Because the average COPD patient doesn't exacerbate all that frequently, these trials might need up to a year of treatment and hundreds, if not thousands of patients to be able to detect a change in that primary endpoint. So it can get really expensive. It can deter a lot of drug companies from wanting to get into COPD and run these types of clinical trials. Now, there are several other endpoints that are often used in clinical trials. So lung function, 6-minute walk distance, various symptom scores, and all of these have various strengths and weaknesses and their own biases. But ultimately, there's no single biomarker or outcome measure that can uniquely and comprehensively capture health status or predict response to therapy or disease progression. So there really is a need to develop new biomarkers, perhaps even composite biomarkers that can contribute to a more holistic and longitudinal picture of what's happening to a patient, especially in real time. I just realized I did not show the that this was on, but anyway, this is not an easy process, but we have made some progress. We can see certainly how the COVID pandemic has really pushed healthcare to adapt much more rapidly to the digital realm. While the technology, Zoom, was existent pre-pandemic, there were multiple barriers to actually implementing it in the real world. Issues with data security, privacy, what's acceptable to patients, what insurance companies will cover. But I think the pandemic really forced us to break through much more quickly. So for example, in my hospital, we went from all inpatient clinic visits to Zoom clinic appointments within the matter of weeks, just because we were forced to. Clinical research is facing a similar impetus. Clinical trials are looking increasingly at ways to implement digital technologies to facilitate remote visits, to be able to monitor participants and collect data outside of the clinic and in a more real-world setting. Technologies that measure mobility and physical activity are amongst, I think, some of the most advanced in terms of digital and remote assessments. But for the most part, they're not that well established, particularly in COPD drug trials, and are mainly in the earlier exploratory phase. To get them validated and accepted and used widely in clinical research, and particularly in these registrational large phase 3 clinical trials, this really requires coming together of multiple types of expertise, whether it's technical, clinical, or regulatory, and a stepwise approach. So this is somewhat of a busy slide, but I think it nicely outlines a roadmap to how we can ultimately adopt these digital monitoring outcomes, mobility outcomes, starting with the concept to the technical validation to clinical validation, ultimately to approval. Throughout these steps, we need to be having close engagement with health authorities and ensuring that there's really transparency, especially with the data collection process, how we manage the data, how we interpret the data, and also partner with various stakeholders from the scientific and patient community. There are multiple approaches to getting there. It's not easy. I can say from personal experience, I'm currently involved in a clinical trial, not for COPD, but also for another respiratory indication where we're investigating a multi-sensor device that monitors activity. It was challenging to get funding for it. And because we've made it an optional assessment in our study, it's been a challenge to get sites and to get patients to participate. There's a phone app, which is theoretically very easy to use, but we've already lost some patient interest because, for instance, the phone wasn't charged, the app wasn't updated properly on the first go around. When budgets get cut or we have slow enrollment in our studies, often it's these types of exploratory digital endpoints that are sacrificed first because of all the challenges and the uncertainty surrounding the data and how these technologies are implemented in the clinical trials. For instance, how do we interpret what is considered a clinically meaningful change in a patient's cadence or stride length or turn velocity in the context of their COPD? You know, a lot of these things are still under investigation. How do we differentiate between a true signal versus noise and the variability that's just part of people living their lives in their own homes? Obviously, the environment is less controlled when we collect these data, you know, in the patient's real world living situation than at a clinic site. So I think we really need to have a long-term vision of how these types of biomarkers have the potential to revolutionize the field and change our clinical practice, and come up with ways to effectively integrate these digital mobility outcomes in our clinical research. It has been done successfully. There are a few examples here where DMOs have gained regulatory qualification. So for instance, in the indication of Duchenne muscular dystrophy, In 2019, something called the stride velocity 95th centile became the first wearable-derived clinical outcome assessment that was qualified by the European Medicines Agency for use as a secondary endpoint in trials for Duchenne muscular dystrophy. There's a particular pathway, qualification pathway that the EMA has for novel methodologies to be developed in medicines. Sarah earlier mentioned the Proactive initiative for COPD, and so this is an integrated tool which combines questionnaire, but also a digital activity monitor. And that was, the EMA also offered a qualification opinion on the use of this tool. So with Mobilise-D, the scope is, I would say, much broader. We're not just looking at one single indication or one disease, but four. So cohorts in COPD, Parkinson's disease, multiple sclerosis, and hip fracture. And this is, again, as I mentioned earlier, something that really is going to require the collaboration and effort of multiple stakeholders, industry partners, and drug companies who are willing to take a chance on novel biomarkers, but also the support of regulatory authorities, the understanding and buy-in from patients who participate in these clinical trials, healthcare providers, and payers, people who will ultimately have to help pay for these technologies. So anyway, hopefully that provides a little bit of an overview of how we view these types of digital endpoints. And with that, I will hand it over to Demetrius to talk more about physical activity as an outcome for COPD.
Well, thanks a lot, Sarah, for these really interesting insights from our industry partners. It's also really interesting. And I'm now very happy to hand over to Dimitrios Megaritis, who will give a talk on physical activity as an outcome in COPD. Dimitrios is a PhD researcher in the team of Professor Ioannis Voagitsis in Northumbria University in Newcastle. His research focuses on mobility and exercise testing in patients with COPD and on effects on muscle training and non-invasive ventilation applied during exercise in healthy people and patients with lung diseases. Within Mobilise-D, Dimitrios is currently collecting data for the clinical validation study and is working on COPD data from the technical validation study. So I'm very happy to hand over to Dimitrios.
Thank you very much, Anya, for your kind introduction. So my presentation today is about physical activity as an outcome in clinical trials in COPD. The Mobilise Consortium published a scoping review assessing the clinical utility of digital mobility outcomes in 4 different disease entities, namely chronic obstructive pulmonary disease, multiple sclerosis, Parkinson's disease, and hip fracture. This table is from the scoping review, and it presents the responsiveness of different digital mobility outcomes used as endpoints in clinical trials. As you can see, the majority of the digital mobility outcomes in multiple sclerosis, Parkinson's disease, or hip fracture refer to the pace, rhythm, and variability. For example, gait speed, cadence, stance duration, or swing duration. On the other hand, the COPD studies primarily focus on the volume of physical activity, including steps per day or daily walking time. So the next step could be to undertake a systematic review and meta-analysis to evaluate the effects of all available pharmacological and non-pharmacological interventions on physical activity outcomes, to further explore which physical activity outcomes have been used as endpoints in clinical trials, and finally to identify the clinical and methodological gaps in the literature to optimize future study designs. In the next slides, I will present to you the results of this synthesis. So 5,530 records were screened, 74 studies were included in the present analysis, and the last search was performed in July 2021. For the present analysis, 3 different types of interventions will be presented. The first type is physical activity behavioral modification compared to usual care. This type of intervention includes pedometers to measure daily step counts during the intervention period and implement dynamic target goal setting based on the step counts of the previous period using either a mobile application, a website, telephone feedback, or face-to-face meetings with the provider of the intervention. The second type includes pharmacological interventions, in this case, bronchodilator therapy compared to placebo, while the first type includes exercise training as part of a pulmonary rehabilitation program, outpatient pulmonary rehabilitation program, or community-based program compared to usual care. Furthermore, the addition of physical activity behavioral modification interventions applied alongside exercise training compared to exercise training alone will be presented. So, compared to usual care, exercise training did not exhibit significant improvements in either steps per day or daily walking time. This improvement that you can see, which is 482 steps per day, was not statistically significant nor clinically meaningful. Bronchodilator therapy compared to placebo significantly improved steps per day by almost 400. And as you can see, there is no study exhibiting a positive effect in favor of the placebo group. Physical activity behavioral modification interventions compared to usual care significantly improved both steps per day and daily walking time. The improvement in steps per day was a little bit over 900, while the improvement in daily walking time was almost 12 minutes per day. Physical activity behavioral modification interventions applied alongside exercise training significantly improved steps per day by almost 700 compared to exercise training alone. The final physical activity variable is movement intensity, but neither physical activity behavioral modification nor exercise training interventions were successful in significantly improving movement intensity. However, following exercise training interventions, the p-value was 0.05, being very close to significance. So the main findings are the following. Only physical activity behavioral modification and pharmacological interventions led to significant improvements compared to the control in steps per day, while the most evaluated physical activity outcome was steps per day. Daily walking time was responsive after physical activity behavioral modification interventions, but not exercise training interventions. Movement intensity was not responsive after physical activity behavioral modification, but was nearly significant following exercise training interventions. It should be noted that a small number of studies was available, leading to less power in this type of physical activity outcomes. In order to allow comparisons between different types of interventions, steps per day will be used since they have been assessed in clinical trials employing all different types of interventions. Bronchodilator therapy led to significantly improved steps per day compared to placebo, likely by reducing exertional breathlessness, reducing dynamic hyperinflation, and improving lung function. However, physical activity behavioral modification interventions led to a twofold improvement compared to bronchodilators, thereby promoting the assumption that there are significant but limited improvements in physical activity when lung function is ameliorated. In order to further improve physical activity, the behavior of the patient towards physical activity should be modified. Finally, to close my presentation, I would like to add that in COPD, the responsiveness of novel digital mobility outcomes needs to be assessed following all different types of pharmacological and non-pharmacological intervention, as well as adverse events such as exacerbations. Thank you very much. And now I would like to pass you over to my colleague, Laura.
Thanks very much, Dimitrios, for this nice overview of a systematic review that costed you a lot of work to go through all these studies and collect all these data from the literature. I think you could also conclude that we perhaps need more sensitive outcomes to pick up the effects of our interventions. That could be another reading of the data. So now it gives me great pleasure indeed to introduce our colleague from Barcelona, Laura Delgado. Laura works in the IS Global in Barcelona, which is the center where also Professor Judith Garcia-Aymerich works, and I believe it's fair to say that she's the first to put physical activity really on the map by looking at physical activity in a large cohort study, the Copenhagen City study, and that sort of opened our eyes to the importance of physical activity in a cohort of patients with COPD. And so Laura is there a PhD researcher at IS Global in Barcelona. And her research focuses on characterizing mobility in patients with COPD, taking into consideration both objective measures derived from digital technologies as well as the patient perspective. And I'm really happy that Laura will discuss this patient perspective based on a literature review. We've heard now how important physical activity or digital mobility outcomes are from a clinician's perspective, a clinical researcher's perspective, and also from the pharmaceutical industry perspective. But how important is it when we look at the patient? And I think that's why we are doing all this for in the first place. So Laura, no pressure on you, but the floor is yours.
Thank you very much for the introduction, Thierry, and thank you everyone for joining us today. As Thierry said, I will talk about the patient perspective from the literature, and I will present some of our qualitative results so far. And just to start with a disclaimer, today I'm going to talk about mobility as the ability to walk, which is the operational definition we used in our work. And what could we say about walking? First, walking is crucial for an active and healthy aging. But as we grow older and in the presence of chronic condition, walking changes. And because of this, research on how to assess and modify walking has become a global priority, as we have seen in the previous presentations and in the work from Mobilise-D. Therefore, for research to be impactful, it is key to understand which are the aspects of walking that are meaningful to individuals, especially to those living with impairment. Taking all of this into consideration, we developed the following research questions. How do people living with chronic conditions experience walking? And with this question, we work on a qualitative paper that is soon going to be published in Age and Aging, where we focused on identifying and synthesizing the walking experiences of individuals living with different chronic conditions, including but not limited to COPD. And what we performed here, we did a systematic review of qualitative studies, and then we perform a methodnography, which is basically a synthesis process where we compare and interpret individual studies in order to generate new theory. Methodnographies have 7 different phases as they were developed methodologically by Knoblit and Haar. And here you can see the first 2 phases that are closely related to the systematic identification of studies, and the following 5 phases where we did the qualitative synthesis, and we compared and interpreted the results in a process called in methodnography's translation of studies. And to start already with the findings here, so from over 2,000 papers that we identified in 7 electronic databases, we underwent a title, an abstract, and a full text screening, and we included in this review 117 papers that were exploring walking experiences in the presence of 6 different conditions. You can identify here Mobilise-D conditions, and in COPD in red in the higher part. And from the synthesis of these 117 papers, what we found is that there are 7 interrelated themes that explain the experience of walking in the presence of different conditions. Because today we're talking exclusively about COPD, I will use COPD examples, but I think it's important to understand that one of the key findings of this work was the fact that the 7 interrelated themes are similar or common to all conditions, which suggests that there is a similar walking experience beyond the signs and symptoms of the disease etiologies. Okay, the first thing that we found was that in the presence of mobility impairing conditions, walking deteriorates and begins to require a conscious effort, resulting in an awareness of walking that was not there before. Patients start noticing changes in their walking, and because of this, they start noticing an increase in physical exertion or to react to complex environments. In this example from a COPD patient, we can see how the patient talks about being aware and planning ahead. No? So I'm always aware of the distance of how far I have to walk. I'm always aware of the temperature, so it's almost like a second nature to always plan ahead. Also, patients tend to describe the walking changes compared to an effortless past where walking was automatic or something that was not changing or impairing their ability to move. Then we found that the walking experience is multifaceted, and it has and there is a constant interplay between a physical, a social, and a mental component. In regards to the physical walking experience, patients often describe a loss of physical function associated with different signs and symptoms and to changes in their walking performance. So in this example, we can see how in COPD, one of the main symptoms that patients describe, and that it's closely related to the presentation by Henrik and Sarah, is shortness of breath, of breathlessness. No, I still can walk too far. I don't get any pain, but I just get a short of breath and that run out of wind. I wouldn't be able to vacuum or mop anyway because I run out of air too quick. And together with breathlessness, patients with COPD tend to mention other symptoms such as weakness, fatigue, or pain. And in regards to their changes in their walking performance, it's interesting to see how they are not only describing it in terms of the distance, so how far they can walk, but they also talk about how fast they can walk, so in terms of speed, and even in terms of duration, for how long are they able to walk. When it comes to the mental and emotional walking experience, we can say that most of the patients talk in terms of a loss and mourning of physical function. And this connects to feelings, usually to feelings of anger, anxiety, stress, or as we can see in this example here, embarrassment and distress. However, there's also positive feelings that are being associated with the walking experience, especially when it comes to achieving goals, when we have patients discussing satisfaction, achievement, motivation, or fulfillment. And when it comes to the social walking experience, we can see here a good example of how social networks and the social support work for patients, and it's related to their walking experience. Now here, the social support from the partner helps the COPD patient to engage in walking related activities such as walking the dog. In this social experience, we also identify topics like the role and identities, how it changes the role of a participant within their family or their community, and the senses of belonging and otherness that come with the walking impairment. We also found that walking experience is framed within a context. And when we talk about the context, we describe a physical context related to the environment, to the climate or the weather. Like in this example, the cold weather does affect my mobility. But we also talk about a socio-cultural context associated with the cultural norms where participants engage, or even a personal context closely related, especially in the case of COPD, with the aging and the comorbidities as they were explained by Henrik before. We then found that the walking experience is there's a link between the activities of daily living that individuals want to perform and their sense of self. So here we notice that for participants, the desire to perform some of these activities that can be basic, such as bathing, dressing up, they can be instrumental, such as performing household chores, going grocery shopping, here in this example, doing the dishes at home. They can be leisurely when we talk about the example of dog walking or engaging in physical activities, or they can even be work-related for younger participants. And the fact that patients are able to perform these activities independently makes the walking experience something symbolic of independence, of normalcy, and of a sense of self for individuals that see their walking changing. Finally, the last theme that we included here was the behavioral and attitudinal adaptations resulting from the walking experience. So when individuals experience changes in their walking, they usually tend to adapt and to assume different attitudes in regard to the walking. And some of these adaptations may include performing physical activity to maintain function, managing changing abilities, prioritizing between the activities they can do or cannot do, planning ahead, as we saw in a previous example, or even using assistive technologies, as we can see in this example. No? The supermarket is really close, but I have to use the car or a walking friend. Otherwise, I won't make it. taking the 7 themes into consideration, we were able to develop this conceptual framework of the walking experience, where you can see some of the ideas that I explained before. Now, the walking experience is multifaceted, and it has 3 main components: a physical, a mental, and a social one. It's framed within a context, and it's connected to the activities that individuals want to perform. And the walking experience also creates a link between those activities that the individual wants to perform and the individual's identity, sense of self, and the adaptation it has to engage with. And finally, just to give you some take-home messages from this presentation, as we saw, the walking experience is a complex and meaningful aspect of health for individuals living with COPD. It's multifaceted as it has 7 different themes. It's dynamic because it's changing. It's modifying and being modified all the time. And it's universal because I explained example from COPD, but this was common to all the conditions we were looking at in the review. And finally, from the conceptual framework, I would like to say that we try to create a framework that it's grounded in the needs and lived experiences of individuals, and we hope to provide a theoretical structure for patient-centered clinical practice, research, and public health. And I think that's it from my side. Thank you. And I will leave you with Helene now.
Thank you, Laura. I don't see any questions. So yeah, it was really interesting, your insights on the perception of walking from the patient's perspective, and also the development of the conceptual framework. And I know how much the work was. It was a tremendous amount of work Laura and the other team members did. So thanks again.
Thank you.
Now, it's a great pleasure to me to hand over to our last speaker, to Helene de Meyer, who will give an insight into the operational side of the Mobilise-D COPD cohort study. So she will give an overview how we conduct the study and everything. Helene is a postdoctoral researcher at KU Leuven and an assistant professor at Ghent University, and she also co-leads the COPD cohort together with Thierry. Helene's research focuses on the importance of physical activity in COPD, the effect of interventions, and the standardization of the assessments of physical activity outcomes. So she completely optimally fits to the Mobilise project. She's very experienced in these fields and recently also co-authored a white paper on the standardization of physical activity assessment with an international consortium of experts. Within Mobilise, besides co-leading the cohort, she's also involved in planning, analysis, and conduct of the clinical validation study. So I'm really happy to hand over to you, Helene.
Thank you, Anja. I hope you can, in the meantime, see my screen. So I will give a very brief introduction into the COPD specific part of the clinical validation study. So the general aim, or the main aim of the clinical validation study, is to test the clinical importance or the clinical validity of digital mobility outcomes. And this is tested against clinically relevant constructs. So beside the general primary outcome that we test, which is a measure of disability, we also have our own or cohort specific primary outcomes. And I wanted to give you some background on the outcome, the primary outcome we have chosen as COPD cohort and why we did so. So for COPD, the primary outcome is the occurrence of COPD exacerbations. And if you want to have some more detailed insight into our study protocol, I want to mention that it has been published this year in PLOS ONE, so you can read more on the general protocol of the clinical validation study. So why acute exacerbations? So Henrik Watts already introduced exacerbations and the importance related to survival. So exacerbations are acute or periods of acute worsening of the COPD. And it has been defined as periods where the symptoms of our patients are higher than the day-by-day variation. And we know that besides the effect or the worsening, acute worsening of the lung function, patients also experience an acute worsening of their quadriceps force. And this has been shown some years ago for example, in this study published in the ERJ, where if you compare the stable phase of a patient compared to a measure of quadriceps force at day 3 of their acute exacerbation, you see a significant drop in the maximum muscle force. And the problem is that patients will not recover completely after such an acute exacerbation. And this is a systematic review showing this effect on muscle force, where with the first exacerbation, you see a drop in muscle force. This muscle force will not recover completely. And with the second exacerbation, actually the drop is even worse. And so patients will decrease their muscle force over time. And for us, maybe even more interesting is the impact on mobility or physical activity. And Fabio Pita showed many years ago that as compared to stable patients, which are here shown in the orange dotted line, patients at having a severe exacerbation, so an exacerbation requiring a hospital admission, that during the exacerbation, the physical activity is very low. But even 1 month after discharge, patients have still a significant low physical activity, especially compared to patients with or stable patients with COPD. And we could show as part of the proactive project that if you follow up patients with COPD for 1 year, and if you look to the decline patients have in their physical activity, that patients experiencing exacerbations have a faster decline in their physical activity. If you compare here the first dot or patients that did not have any exacerbation during the 1 year follow-up, if you compare then the decline during follow-up in patients having at least 1 moderate exacerbation, which is an exacerbation requiring changes in medication but not requiring a hospital admission, that these have a small or already a faster drop in their physical activity, but especially patients having multiple of those moderate exacerbations or patients having at least 1 exacerbation requiring a hospital admission, those patients have a significant faster decline in their physical activity or mobility. So exacerbations bring patients in a very negative spiral, and patients will come in this spiral. And as Henrik already mentioned, these exacerbations are highly related to a faster or a higher mortality in our patients. And on top of that, exacerbations are very important from a patient's perspective. And this is, I think, a very elegant study recently published where the patient experience has been questioned during experiencing an exacerbation. And here you also see that this how patients experience exacerbations is multidimensional. Patients experience or patients talk about physiological changes. They feel that they are less strong as compared to the period before the exacerbation. They have more symptoms, but also in terms of family, they feel that they are having problems in their relationships. They are feeling isolated because of the exacerbation, because they cannot do whatever they want to in terms of mobility, and they have higher symptoms of, for example, anxiety, depression, and fatigue. So also from a patient perspective, it has a high impact. So this is why we have chosen exacerbations as our primary outcome. And how will this be tested? Well, this is the this is a scheme showing the clinical validation study where patients are followed up every 6 months over 2 years. And at every time point, so every 6 months, digital mobility will be assessed. As Dimitrios said, up until now in our COPD field, we have mainly focused on physical activity, mainly the amount of physical activity. So for this project, we are really shifting and also testing the importance of other digital mobility outcomes, such as real world walking speed, which is our primary outcome, but also gait characteristics such as cadence, as Sarah also already introduced. So how will we measure the occurrence of exacerbations? Well, we will include moderate and severe exacerbations. And as I have already mentioned, moderate exacerbations are those events or acute worsenings of the disease requiring a medication change. more detail the intake of corticosteroids and or antibiotics. And a severe exacerbation is defined if the patient needs a hospital admission or at least an overnight stay in an emergency room or a hospital at home visit. As a remark, because sometimes patients re-exacerbate and this can go very fast, we standardize our measure of physical activity across all sites, and we only include the exacerbations if there is at least 3 days of a change in medication. And also if the exacerbations come within a time frame of 14 days, then we include, or we don't define this as a new exacerbation, but it will be part of the first exacerbation. So then these will not be 2 separate events. And this is important because the definition of exacerbations, it's not that easy to standardize across centers, which is highly important in this study, of course. How do we know whether patients experience an exacerbation? Well, we ask patients to complete on a daily basis a diary. So this is our main information. I have included here a screenshot of our diary. So we ask patients if they change their medication, and we ask them to note the date that they started antibiotics or corticosteroids and or if they were in the hospital. Then notes from the investigator during the trial. So if patients contact us and they report an exacerbation, we make note of this. The interview with the patient at the study visit. So on every study visit, we have an interview with a patient and ask them about medication changes, and also information on hospital records can be used. This is our primary outcome. Other COPD-specific measures that are measured every visit, because we know that they are important clinical measures in this patient population, are, of course, spirometry, giving us information about the severity of the airflow obstruction, quadriceps strength we measure on every visit, and then physical activity from a patient's perspective, as Sarah already introduced, is an important outcome in COPD patients. So I will shortly give some information on the patients we have included in our COPD cohort. So the sample size calculation gave us information that we needed 600 patients, and we managed to recruit 600 patients across all sites during a recruitment period of 1 year. For this, we had to join forces across 6 centers in Europe. In the blue line, you see the inclusion of our patients. We are now already at 80% of patients that are retested at T2, which is a 6 months of follow-up, and already more than 200 patients came back for our 1-year follow-up visit. To give you some insight on which patients we have included, I have made some first graphs on the baseline characteristics. So in terms of age, I think we are covering a very broad spectrum on age. We have even 80-plus-year-old patients that are recruited in this trial. So it's really a very wide spectrum. Also in terms of functional exercise capacity, both in absolute values as well as expressed as a percentage of the predicted value, we have a high spectrum of patients, or in terms of functional exercise capacity, the spectrum is also very wide. In terms of the severity of the lung disease, we mainly recruited patients in cold stage 2 and 3, but we could also recruit patients in the very mild and the very severe stages. Exacerbation history. We have mainly patients without any exacerbation during the 1 year before being included in the study. And this is important because having had an exacerbation in the history is the most important predictor, or one of the very important predictor of having a subsequent exacerbation. So for this, the lower number of exacerbations was surprising, but we do think that this can be explained by the COVID pandemic, where we know that the number of exacerbations was much lower across the world as compared to the pre-pandemic situation. And also in terms of shortness of breath or dyspnea, the entire spectrum has been covered. And maybe a final word on a COPD-specific research question we do have and we will be able to answer is whether these DMOs, so digital mobility outcomes, will change after pulmonary rehabilitation, which is, as Henrik Watts already mentioned, one of the most important non-pharmacological treatments. So for these patients at the start of their pulmonary rehabilitation program, which is typically a program of 8 to 12 weeks, these patients at the start of their rehabilitation program were invited also for the Mobilise-D or the clinical validation study. And so these patients here between baseline and 6 months will have had a period of 8 to 12 weeks of pulmonary rehabilitation. And we will compare the change in these DMOs with patients who did not follow a pulmonary rehabilitation. So this will give us a first idea on the changes that we can expect in these outcome measures. So then I will give the word back to Thierry because maybe we still have some time for Q&A.
Okay, thanks very much, Helene. And I think this is also an appropriate moment to thank all the sites that helped us to include during a corona pandemic 600 patients in, I think, record time. So this was only possible with all the hard work from people in all the different sites across Europe. So thanks very much. And I hope the work is also appreciated by people that are attending this webinar. Can I just close off the webinar perhaps with a very general but yet specific question to all panelists? And I want you to answer it from your own perspective. We're now moving from a clinical visit to home measurements of patients and how they perform in real life. And we're using digital mobility outcomes, which means that we're using platforms and so on. So from your perspective, what is the biggest opportunity and perhaps at the same time the biggest challenge in making that move from clinic to real life situations? And I think I would love to have the perspective of first maybe the clinicians. So Henrik, what in your opinion would be the biggest challenge and also the biggest opportunity?
Yeah, thank you, Thierry. What I think is the biggest challenge is the interpretation of the data, because we will collect lots of data, but we managed it also with the physical activity measurements that we did so far. So I'm very optimistic that we will manage it. And the opportunity I see, I would say, is that we get much more insights into the clinical situation of our patients, and we are much closer to the patients than we were before.
Yeah, Sarah, you also tackled the clinical perspective. So could you give it as your opinion from your perspective?
Yeah, I think the main challenges are probably going to be trying to get clinicians to be able to start picking up these digital mobility outcomes and being able to use them and give them to patients when they're already very busy and have lots of things to do. So I think that's probably one of the main challenges that I would say. And then opportunities wise, I think is going to be being able to, similar to what Henrik said, be able to monitor patients more frequently. So really picking up when a patient is deteriorating and being able to intervene a bit quicker than we have been able to do traditionally when we've just measured patients once a year in a yearly clinic.
Okay, thanks for that. Sarah, from the pharmaceutical industry's perspective, how do you look at these developments into out of the clinic and into the real life?
I think I touched on some of these challenges and opportunities. I think one of the main hurdles and opportunities is understanding what the data means. There are so many endpoints and parameters and metrics that can be measured with some of these devices. How do you differentiate the signal from the noise? How do we correlate it to something that's clinically meaningful? And then how do we translate that into something that's going to be accepted by regulators, patients, providers? But the opportunity is there to learn a lot about patients from a longitudinal and real world setting. And I think, as I mentioned, it's sort of at the leading edge of being able to implement clinical research from the clinic site to something that's remote and much more convenient for patients.
Yeah, okay. Thanks for that. Dimitrios, you're a PhD researcher working with these data. So from a researcher's perspective, what is, in your opinion, the opportunity that we have in digital mobility outcomes? And again, the challenge as a researcher, as a clinical researcher?
So from my perspective, I think we need to assess which novel digital mobility outcomes are mostly suited for COPD patients, because up until now, only the volume of physical activity has been assessed. And we need to see which physical activity outcomes are, first of all, sensitive to interventions such as pulmonary rehabilitation, as I mentioned earlier, and Helene explained it more in depth. Is it gait speed, more sensitive and more reliable measurement, or maybe measures of variability? Variability in stride length, in stride time, etc.
Okay, thanks. And Laura, do you think the patients will learn something from all this exercise? And again, moving to physical activity monitoring or digital mobility outcomes, whatever it will mean in the future, will they see the benefit of these type of outcomes? Do you have any feeling for that?
I would say yes. I think for patients, we notice that mobility is meaningful already, but the idea of having clinicians or researchers working on mobility, that it's important for them, and that might not be the most clear symptom of a respiratory condition like COPD, will improve their medical care and, let's say, their long-term care, maintain their function. And we have the possibility to start looking at all the other things that we find in this review, the context. By going outside of the clinic and going into the real world, we can talk about the context. We can see how all the other aspects are affecting the physical function of patients. So I think there's a lot of work there that can be done.
And we're definitely capturing, of course, something that is really very close to their existence with the disease, of course. And this was true across the different cohorts of patients that we looked at. So I think that definitely is what you also told in your section. Helene, any final last words?
Maybe also as a researcher, then I think we should convince the world that this is device agnostic, or at least that all devices are giving the same information. Always, if we talk about physical activity, then people say, yes, but you cannot compare across devices, so we cannot interpret and we cannot use this. So for me, this is, I think, the most important challenge. And in terms of opportunity, I think I agree with what has been already said, that you have a day-by-day or even more granular information on patients, which can give us a lot of information.
Okay, well, thanks for those insights from all of you. Anja, back to you to close the session.
Well, yes, then thanks a lot also to you, Thierry, for co-chairing this session, and for Mara for organizing it. And we hope that we gave you an insight of our COPD cohort and that you could understand and learn a lot. And yes, we wish you a nice evening, and yeah, see you maybe soon at the next webinar.